I also want to thank the Africa CDC for quickly organizing this. What is the estimate of the number of people that needs to be tracked regarding contact tracing, and how far is this surveillance going? Regarding the risk to the region and the risk to the rest of the continent, what is the recommendation regarding potential travel and movement restrictions? You also mentioned that because we don't have treatment and vaccines, the way to respond to this outbreak is largely via public health measures. I would like you to clearly state out what those public health measures are.
You know, in the context of any outbreak, even if it's not Bundibugyo, any outbreak, mostly when it's a hemorrhagic fever, what we do, we need to isolate cases. All cases, suspected cases, must be isolated. And we need to provide the PPE to health workers for them not to become sick while taking care of others. We need also to do what we call the contact tracing. We need to identify all individuals we think were in contact directly or indirectly with those who are sick. It's just that approach that can help us to know the magnitude of this outbreak. And we need also to reinforce the cross-border surveillance and the screening. Now we can use the GenExpert, we can use the genomic sequencing capacity at country level, but we need to see how we can scale up that. We are also talking about IPC, infection prevention and control, like washing and safe injection practices and others. Then we are talking about funerals. What we are saying, we need safe and dignified funerals that will protect families and friends. The last one, it's about community engagement and risk communication. It means what kind of information we are providing to communities for them to know what are symptoms, and even to avoid, in some places, not to eat some animals. You know, we started to discuss that for some outbreaks in DRC in the past. Now, when you are asking me about the potential decision we can make on the movement of people, you know, when you put in place the public health measures, when you can test people, you don't have to restrain people to fly or to move. We just need to put in place these measures, because that measures can show that progress can be made. If we had to take appropriate measures in Ituri before, maybe we will not have the case in Uganda, and vice versa. If we had to take appropriate measures around the person passed on in Uganda, maybe we could avoid some other cases either in Uganda or back in DRC. I think for now, we are not recommending countries to have a kind of travel measures in place, but we are just recommending all of the public health measures that I listed.
The issue of the contacts and the reproductive numbers and what we are dealing with. But to add to what Ngashi was telling you is that there are unknowns, there are things we don't know. For now, the 300 plus are DG2U about cases we suspected and probable cases right now cannot be the true picture. So to determine the number of contacts, we gave us a couple of days to go on the ground and do the contact tracing, line listing of the cases. But to give you public health assumptions that we are working with diseases like Ebola, if you look at the reproductive number, it's between 1.3 to 2. That is, for those of you who are not in this field, if a case of Ebola, you talk about more than 2 persons who will be maybe affected from that disease. That's the reproductive number, though it's not high as influenza diseases or COVID-19 or other diseases that, for example, if you took COVID-19, the Omicron variant, you would talk about 8 to 10 reproductive numbers, and Delta variant, you would take about 5 to 8. For Ebola, we're talking about 1.3 to 2. But to know the magnitude of the number of contacts in the two countries, we have to do line listing, contact tracing, and case finding in the communities that are affected. One of our colleagues asked about whether or not there was not precaution taken at the contacts about the dead person in Uganda. We know that from evidence that cadavers or dead person are at higher risks of transmitting the disease to others. If people did not take precautions, we have to do the risk profiling of the healthcare workers and other people who did not do the safe and dignified barriers. But let's be clear, as DG and others were saying, not that we don't have medical countermeasures right now, so there are no public health countermeasures. And he was very, very clear with some of the public health countermeasures, using your gloves as healthcare workers, having your gowns on, washing your hands and taking the precautions. Intensive community engagement is important. Rigorous coordination are some of the public health countermeasures. Doing safe and dignified barriers is important. Isolation, testing at the point of care, and presumptive treatment can also work. That's the palliative care, reduces the severity of the disease. Those are some of the public health measures that we are taking right now to reduce the spread of the disease.
To add on what Toba just said, I think on the contact tracing, the waking number that we use when we plan is an average of 20 contacts per case. Because of the range from 10 to 30. But that number in urban areas is much higher than that. I think that is just starting now. I think we'll see also how we are performing on the contact tracing once we get all the community health workers engaged for the actual identification and follow-up of contacts. Now, I think on the public health measures, I think DG explained very well the measures. I just wanted to say that we are dealing with a zoonotic disease. I think that's where that whole issue in the surveillance of One Health becomes critical to ensure that the vet department is equally engaged with the health department to ensure that we are also tracking what is happening with animals. Now, on the last question about whether this is a new strain or not, the DG presented, it's not new. We had already 2 outbreaks in the past, one in Uganda in 2007, 2008, and one in DRC in the Isiro area in 2012. But the fact that since then there have not been any other outbreak has also made that the research has really been advanced with the Zaire, because there have been many Zaire outbreaks. That's why we have been able, because of that, to get vaccines and therapeutics and diagnostics. I think now that Bundibugyo is coming back, it is also a wake-up call. As you heard that yesterday already there was a meeting of the research team to just now start planning the research that will support this trend as well.
In addition to what Dr. Ngashi said, we didn't neglect Bundibugyo, no. And when you are discussing with pharma companies, they are also telling you about the market. Bundibugyo is rare. Bundibugyo is not killing like Zaire. Number of cases is small. And the question is, why do we have to manufacture that if there is no market? But as in Africa, now that this is the 3rd outbreak, and this 3rd outbreak is now affecting more than one country, we need to start to see, as my colleague Chanel said, how to accelerate the manufacturing of some of the medical countermeasures. But believe me, if we had Bundibugyo in Western countries, all of these MCMs will be available.